So last time we had discussed, okay, so here it is. So we're going to talk about adjuvant therapy in pancreatic cancer today, includes periampullary cancers as well. So we briefly talked about BRCA, that pancreas cancer is one of the BRCA-associated cancers, and all the guidelines now recommend that patients with pancreatic cancer should undergo germline mutation testing. And so you have the risks here. About 5% patients are likely to be BRCA2. Biliary tract cancer also, I think there are a few papers which show that they may be BRCA2 positive, but it has not made its way into the guidelines yet, but possibly may do. Very important that you differentiate germline versus somatic mutations. Even if you, and we are doing NGS testing in most of our patients nowadays when they progress. So if you do see a somatic mutation with BRCA2, PALB2 or ATM1, it's important that the patient undergoes germline testing as well. Screening is mainly we talk about screening for cancers which lend themselves to a precancerous stage, and high-risk IPMNs or pancreatic intraepithelial neoplasia lends pancreas cancer also eligible for this. And now there are a few papers where they talk about for patients with BRCA cancers, if you are doing an MRI of the breast, then the MRI of the pancreas also should be included. And most of the guidelines also suggest screening for pancreas cancer about a decade before the index patient in the family has been diagnosed. So I think it's very important for you to know about, because it's important we diagnose this cancer early, especially in high-risk patients. The other cancers which lend themselves to screening because there is a precancerous component attached to it are colon cancer, cervical cancer, and breast cancer. So, again, genetic counseling is very important before you order a BRCA test, and positive mutation is associated with increased risk of cancer progression, and is also very important for the family. The modalities recommended are MRI in combination or EUS, and the screening is to be done every 12 months. So this is just briefly, I wanted to talk about this. Pancreatic cancer, 3 epithelial types: exocrine, ductal, and endocrine. You will also hear about acinar cell carcinoma. Again, ductal and acinar very likely treated separately. Acinar is very rare. Usually they have a longer survival, and CA19-9 is not usually raised. They usually present with very large tumors. The last patient I had had a 10 centimeter pancreatic mass, and the AFP was raised, which is slightly unusual in a patient with pancreas cancer. Neuroendocrine we've already discussed in the first session, so we will not talk about. So the adjuvant therapy we discuss will be in ductal adenocarcinoma of pancreas. So gemcitabine has been the standard of care. We talked about that when it was compared in advanced cancers with 5FU, the median survival was significantly better, and 12-month survival was 1-year survival was 18% versus 12% when gemcitabine was compared with the 5FU. We'll talk about how the adjuvant treatment has evolved and what the current standard of care is today. So ESPAC-1 was the first study. I'll just go through the ESPAC story, which is very interesting, led by Professor John Neoptolmos in UK. And I was part of recruiting into a few of the ESPAC studies as well at the Marsden with Professor Cunningham. So ESPAC-1 is a 2x2 factorial design, looked at observation versus chemoradiotherapy and bolus 5FU versus chemo-RT and chemotherapy. And basically the results were that chemotherapy does add benefit in prolonging survival for patients with pancreatic cancer. The study included T1 patients as well. In this study, there was a deleterious effect from addition of chemoradiotherapy. So if you see here, the survival rates, the 2-year survival with the no chemotherapy versus chemotherapy was 30 versus 40%, almost 10% higher. And the 5-year survival was 3 times higher with very good hazard ratios. And you can see the curves start separating at 1 year. The CONCO one looked at the question of gemcitabine versus observation. So now we know that that addition of chemotherapy versus observation is better. CONCO looked at the question of gem versus observation, and this study showed that there was a significant overall survival advantage of 23 versus 20 months, 3 months advantage over observation with gemcitabine. So this study was the pivotal study actually, which established the 6-month as the standard of care or the course of gemcitabine for patients with pancreatic cancer. It did not look into radiotherapy. So we've accepted gemcitabine as standard of care. The long-term results of CONCO 001 published in 2013, 10-year survival was 8% versus 12%. So remember this figure, median overall survival of 23 months. Go and do your work. So sorry about that. So the next study is looking at the RTOG study. I think these studies are very important. All of these, if you and they have actually got us to where we are today in improving the outcome for our patients with pancreatic cancer. So both the arms in the RTOG study got 5-FU radiotherapy, but in one of the arms they had continuous infusion of 5-FU, and in the other arm the patients received gemcitabine pre and post. And this study included pancreatic head tumors only, showed slight benefit of gemcitabine over 5-FU in pancreatic head tumors. So if you look at the 3-year survival was 31% versus 22%, and the median survival was 17 versus 20 months, more so in favor of gemcitabine, but it was not statistically significant. More grade 4 hematological toxicity was seen with the gemcitabine. I think for our non-medical oncology colleagues, gemcitabine causes more myelosuppression, while 5-FU causes more of diarrhea and mucositis-like symptoms. Did not resolve the question of radiotherapy because both the arms received radiotherapy. Just to make a point about ESPAC 1, which we discussed, in which the radiotherapy had a deleterious effect. I must say that the type of radiotherapy that was used was quite old, was not as accurate as what we use today. So we cannot actually extrapolate the results to today. So looking at the ESPAC-3, ESPAC-3 was also one of the studies which included patients with periampullary adenocarcinoma. And in India, we tend to see more of periampullary patients compared to the West. So this randomized patients to gemcitabine versus 5-FU, again, more than 1,000 patients. You've seen in the earlier trials, the number of patients were between 250 and 300. So here we wanted to know whether the metastatic story translates into the adjuvant story as well. And we've learned from colon cancer that what you see in metastatic setting does not necessarily mean that you will see it in the early setting as well. A lot of targeted drugs, irinotecan, work very well in metastatic colon cancer, but they do not work in early colon cancer as adjuvant treatment. So that was a reason to do this study, because we know in metastatic setting, gemcitabine is the standard of care. So as you can see, there was no difference between gemcitabine or 5-FU folinic acid. The progression-free survival and the overall survival were pretty much for both the studies. The 2-year survival was also 48-49%, very similar. But what was seen was that the toxicity was lesser with the gemcitabine, and that's why gemcitabine was taken as the standard arm and taken forward for the ESPAC-4 trial design. ESPAC-3 did not show superiority of gemcitabine over 5-FU. The periampullary study had about, I think, more than 100 patients. which also showed that, that there was no superiority of one drug over the other, but also showed that with 5-FU gemcitabine versus observation, so patients who were on observation arm also did as well, did not show benefit of chemotherapy in the periampullary setting. ESPAC-4 took gemcitabine as forward and given 1 grams per meter square 4 weekly for 6 months. So 6 months is the standard of care in most of our adjuvant studies, except in colon now, where we are talking of 3 months. So we haven't started de-escalating in pancreas yet because the survival and the outcomes remain quite dismal. Patients were randomized, again, more than 1,000 patients, to gem versus gemcitabine, capecitabine. Again, the doses of capecitabine are quite high, and very rarely do I see an Indian patient who would tolerate this high dose for 21 days of a 4-week cycle. Most of our patients, I would say, would tolerate 1,250 milligrams per meter square, given twice a day. So primary endpoint was overall survival. The median age was reflective of the previous studies as well. What is interesting is that the surgery to randomization was 9 weeks almost. So I think it's very important before a patient starts adjuvant treatment that they've recovered from the Whipple surgery, which is one of the most complex surgeries that we see in GI cancers. The toxicity, again, I won't go into the details here, was understandably more in patients who were on the gemcitabine, capecitabine, except infections where gemcitabine, in the gemcitabine arm, there was slightly more in this study. But again, overall, very, very comparable. So gemcitabine, capecitabine, the doublet arm did significantly better, 26 months versus 28 months, with a hazard ratio of about 20%. So significantly better overall survival with gemcitabine, capecitabine. And the study showed that well-differentiated patients did better, patients with node negative did better, and those who had an R0 resection did better, so nothing new here. So if we look at all the ESPAC studies, the 5-year survival with ESPAC-1 with the best arm was 21% with 5-FU. And if we look at ESPAC-4, the gemcitabine, capecitabine, it's almost 29 months. So remember this figure of 29 months with ESPAC-4, the 5-year survival. Significantly, so all of these studies have shown that one arm has done significantly better than the other, except the ESPAC-3 trial, which was pretty similar, gemcitabine just about a month longer. The forest plot of all the trials that have been published with GemCap versus Gem show that there is a significant benefit of doublet gemcitabine, capecitabine. So GemCap actually includes both fluoropyrimidine and gemcitabine. If you look at the snapshot, you will see that so the curve drops very sharply within the first year. So most of the recurrences that do happen in the first year itself. And the median survival overall, if you look at the ESPAC-4 study with the gemcitabine arm, is 28 months versus 22 months. We look at the CONCO, the earlier trial. So there has been progress with the ESPAC and the CONCO studies from 21 to 28 months. All of these trials listed here with the references at the bottom, again, are very important studies which have shown us the progress in pancreatic cancer. So this has shown that adjuvant therapy works, but if you read the small print in most of the trials, you will see, we discussed this last time as well, when we discussed the new adjuvant strategy, that only 50% of our patients actually get to adjuvant therapy. Half of our patients do not get to systemic treatment. So we know adjuvant treatment works. None of these patients had neoadjuvant therapy. So basically it means that systemic treatment works. 25 to 30% of patients die in the first year. So gemcitabine and optimal administration of 5-FU do quite similarly, but if you combine them, they do even better. Coming on to the studies which are impacting care today for our patients. I attended ASCO 2 years ago in 2018, and after we came back, we had our MDT. I remember that in the next MDT, we changed practice. We did not even, this was one paper, we did not even wait for the fine print to come in because the results were so staggering and so practice changing, and I feel cost effective because I know the cost of FOLFIRINOX with generics is not more than 10,000 or 10 to 15,000, or even less in places like Tata Hospital or regional cancer centers. So this is not something which is very expensive, and for 6 months it is doable. So this study randomized patients to modified FOLFIRINOX for 6 months versus gemcitabine for 6 months. It would have been nice to have gemcitabine, capecitabine as the standard arm here. So patients were included who had a CA 19-9 level of less than 180. I think all the guidelines do recommend, and I tend to do it as well. We do a baseline CA 19-9, and I always do it before I start adjuvant chemotherapy. Very often you will see that, you see a patient after surgery and the CA 19-9 has dropped. But very often you will see about 10% patients, I would say, in my practice where the CA19 has jumped up to 1,000 or something. You do a PET scan or a CT scan, you will find some form of metastatic disease. So it's very important post-op, you do a CA19-9. It's not very difficult, especially if it was raised before without jaundice. Then initiate a scan before you start adjuvant treatment, because the intent of treatment for that patient is going to change. So within 12 weeks of surgery, these patients were randomized. Primary endpoint was disease-free survival. The patients on this study had CT scans as it was a trial every 3 months. We normally don't do CT scans every 3 months. We do CA19-9. So the median age was 63, very reflective of the previous studies. The median tumor size was 3 centimeter. And you see here that a lot of times I'm asked a question, the patient has such a small tumor, madam, let us not give chemotherapy. The patient has had excellent surgery. But I agree that in most of the clinical trials, patients with T1N0 disease are underrepresented, but they were included in all of these studies. And we know the risk of recurrence is quite high for T1N0 as well in the first 2 to 3 years. So I think it is justified in offering these patients adjuvant chemotherapy. R1 resection in about 40 to 46% patients. So again, higher rates. So we know modified FOLFIRINOX is difficult to deliver, but with the use of GCSF, most of the patients do tolerate it well. So the higher rates with FOLFIRINOX was diarrhea, neuropathy because of oxaliplatin. With gemcitabine, there was enzymes increase in the liver, headache, flu-like symptoms. And so there was one patient who died in this arm. One must remember that before, when we patients do have toxicity, well, some morbidity and mortality associated with it, just as the Whipple's surgery. But given benefit is more towards offering adjuvant chemotherapy. So GCSF use, again, 60% here. I'm surprised. I use it in 100% of my patients, less in gemcitabine. Again, toxicity we've already talked about. So the dose intensity was maintained more so in gemcitabine than FOLFIRINOX. Again, it is expected. This is a difficult regimen to tolerate. Patients have to have a good performance status for us to offer this. So this is the study, these are the results. If you look, everything was better with modified FOLFIRINOX versus gemcitabine. The median overall survival of 54 months compared to 28 months that we had earlier, it's almost doubling. The median disease-free survival with FOLFIRINOX is 21 months versus 13 months here. And 3-year disease-specific survival is also significantly better. With these kind of hazard ratios, we see hazard ratios of 0.75, 0.82, 0.8 in, that's what we've been used to. But seeing hazard ratios of 0.8 0.58, 0.63 is very unusual in adjuvant trials of pancreatic cancer. Hence, this study was practice changing. And as you can see, the curves start separating quite early on for patients, those who do not have an event, and this is the survival and disease-free survival. So I think, as I said, yes, FOLFIRINOX has more toxicity, but most of the time the side effects and the morbidity is manageable in these patients. Coming on to the second study, which was presented last year, again, we were surprised because, like I said, from advanced cancer setting, we move on to early cancer setting. And there are two trials which have made a huge difference for the care of our patients, where the median overall survival has exceeded 12 months in patients with advanced pancreatic cancer. It used to be 6 months earlier. But with FOLFIRINOX, we know that the median overall survival is more than 12 months. So that's why we bring the FOLFIRINOX into early setting and we show that it works. Similar thing happened with the IMPACT trial, where we know that with gemcitabine nab-paclitaxel, the overall survival was significantly better compared to gemcitabine alone. It was about 9 to 10 months with gem nab-paclitaxel. Hence, the trial was done to randomizations to gem nab-paclitaxel versus gemcitabine. Similar doses as were used in the IMPACT study. Patients received this for 6 months. This was the APACT study. The CA19-9 here is slightly stricter. In the PRODIGE study, it was less than 180. I think it was less than 180. I'll just check, sorry. It was 180, yes. And here it was less than 100. So it was slightly stricter criteria in this study, primary endpoint very similar. So baseline characteristics, not much difference. The CA19-9 was almost normal in most of the patients before they started treatment. Median age was pretty similar. Safety profile was very similar to what we saw with nab-paclitaxel, can cause neuropathy. That's the only thing which is significant for these patients, I think. But if you see the results, this trial was negative, which was quite surprising. The curves are literally on top of each other. The hazard ratios of 0.88, 0.82, and the median disease-free survival of 19 and 18 months was not what we were expecting. In a pre-specified group analysis, it did show a disease-free survival benefit in patients with grade 2 tumors, lymph node positive disease, normal CA19-9, and OS benefit in patients with PS1, moderately differentiated, normal baseline CA19-9 and lymph node positive. But the study did not meet its primary endpoint of meeting the disease-free survival. So like I said, it did not meet its primary endpoint. Both investigator-initiated and interim OS were prolonged with the addition of nab-paclitaxel. But again, we always try to tease the data and try and see if it will be positive. So I think we're still waiting for the final overall survival data to see whether we give up on this regimen or we continue. So we still need to investigate this because this is a very effective regimen in patients with advanced cancer. So with the APACT, the MEST median overall survival was 41 months, and here it's 54 months. Again, the difference is, as I said, APACT was more restrictive for CA19-9. In PRODIGE, there was stratification within CA19-9 and the nodal count. So I think we're coming towards the end. One thing I want to talk about is after Whipple's, it's a major surgery we talked about. Quality of life is very important, as clinicians, whether you are in radiation, surgical or medical, very important that you look after the nutrition of your patients as well and refer them on if you, this is major surgery. So very important that patients have access to a dietitian who understands what Whipple surgery is and understands, and you also understand what you need to look for if your patient is failing to thrive. By that, I mean that, patient is continuing on adjuvant chemotherapy and is losing weight. And keeps complaining of foul smelling, bulky stool. So again, pancreatic enzyme replacement therapy, supplementation with omega-3 fatty acids, important. So yeah, I've got this slide. So be mindful of this. So it is uncommon following a pancreatoduodenectomy, but if your patients had a total pancreatectomy, then of course you should make sure your patient is on pancreatic enzyme supplements. The downside is that these enzyme supplements are quite expensive. So it's important that the surgical team counsels the patient before the patient undergoes surgery, because all of these drugs, Creon, there are generic versions available, are quite expensive. And patients have to take these lifelong. So, your patient may not have had a total pancreatectomy, but still may have these symptoms because the remaining pancreas that is there is not functioning as well. Adjuvant radiotherapy, I think there's a lot of debate about adjuvant radiotherapy, and I think we still need to wait for the results of the clinical trials in adjuvant setting. Currently, we do not recommend adjuvant radiotherapy, mainly because of the older trials showing that there was a deleterious effect. SBRT should be recommended as part of a clinical trial or a multi-institutional registry if you're not doing a trial, because the quality of evidence is low. So FOLFIRINOX, I think if your patient has a good performance status, can double the disease-free survival, and also the overall survival is quite good. But to have grade 3-4 toxicity in almost half of your patient post-Whipple's, and only half of your patient do get to adjuvant treatment, is quite significant. So because there are a lot of peri and post-operative morbidity involved as well. So I think very important, make sure your patient has recovered well post-surgery before you start, because you have to hold the hand of your patient for 6 months of treatment. Make sure you have very strict nutritional planning for the patient during chemotherapy. I think we should do that with all our patients, but for pancreas cancer patients, it's even more important. And as you have seen I think I should have made a table with the median survival with gemcitabine, with each trial that has gone on has actually got better. And I think that is because we're selecting patients better, but also there's better treatment upon recurrence. And most of us now are moving towards the neoadjuvant strategy, because 100% patients will end up getting chemotherapy or systemic therapy if the patients have neoadjuvant treatment. And what my practice is, I try and offer modified FOLFIRINOX to all patients, but we know that not all our patients are fit enough to receive this. So I tend to offer gemcitabine, capecitabine as per the ESPAC 4 study, because it does have fluoropyrimidine in it and a gemcitabine as well. And there was an overall survival benefit. We still need to get better, because 20% of patients are still dying in the first year. Very rarely, I've done that recently in a 70-year-old gentleman. I would offer gemcitabine alone in patients who are not well enough to tolerate the combination chemotherapy. Thank you. So if you have any questions, let's discuss them. The only reason why I don't have too many things is so that we have time to interact and discuss. I'm assuming you're from all the branches: medical, surgical, radiation. Let me see if I see anyone I recognize. So any questions? Write it on the chat box, or you can unmute yourself as well. So if we have given NACT, still we give adjuvant? So that's a very good question. So normally we give neoadjuvant chemotherapy for 3 months, and we say that the chemotherapy is for 6 months. So I would give 3 months of adjuvant chemotherapy if a patient has had neoadjuvant chemotherapy. So the one thing I didn't discuss is patients who are BRCA mutation positive are very, very responsive to these DNA damaging agents like cisplatin. And I talked about last time that the only patient I've had a PAT CR was the patient who had gemcitabine cisplatin. So I would probably give the same regimen if a patient has had a good response, and hopefully we'll start talking about TRG, that is tumor regression grade in pancreatic cancer as well, when we come up with more effective regimens. So yes, I would give adjuvant chemo as well for 3 months. Do you use growth factor for modified in all patients? Yes, I mean all patients. I am very surprised that the number of patients in the trial. I think again, there are a lot of funding constraints in countries where there's universal health coverage. I think it's for the safety of patients as well. I tend to give pegylated GCSF 24 hours after the infusional pump has been removed in all patients, because this is quite a toxic regimen. And in patients who are above 65, but if they are very fit, I would start with 25% dose reduction and then scale it up in the second cycle if they tolerate it well. So in less fit patients, do we go for gem cap or gem alone? So again, it's a very subjective thing. Like I just said, I had this 70-year-old gentleman who I did not think would be fit enough for a doublet just post Whipple's. So what we have done is we started with gemcitabine. And if he tolerates it well, I will add capecitabine from the second or third cycle. So my aim would be to give a doublet if possible. So sometimes, you may have a patient who sits in your clinic 2 weeks later, 3 weeks later, and they're not as fit as you would want them to be, but with time and nutrition support, they would get fitter. So I usually then add capecitabine with the second or sometimes third cycle and try and complete 6 months of adjuvant chemotherapy. How do you select between GemCap versus Gem-Nab-Pacli? So I actually am not giving Gem-Nab-Pacli in adjuvant setting, but I know a lot of my colleagues who are giving it, because I was slightly surprised with the APAC data. And, like I said, from colon cancer, if you truly want to practice evidence-based practice, the study did not actually meet its primary endpoint. So I tend not to give Gem-Nab-Pacli in my practice, but I know a lot of my colleagues abroad and here are giving Gem-Nab-Paclitaxel, which is not wrong, because as you saw that the pre-planned analysis did show there was a benefit in some patients who had a normal CA19-9 or node positive disease, or they had a moderately differentiated adenocarcinoma. I have not been able to do that. So I either go with FOLFIRINOX or Gem alone or GemCap. So what is the role of Gemcisplatin? So, again, you've caught me here. The evidence is not very strong for gemcitabine cisplatin. But if a patient has a BRCA positive disease, like I said, some of us, given the data from other cancers, we know that these patients have a fantastic response to platinum-based therapy. And, this is a drug which costs 100 rupees. It is not very expensive. So if a patient is BRCA positive, I would prefer to give gemcisplatin, neoadjuvant and adjuvant. And again, the patients are very rare. Incidence is 3 to 5%. Very unlikely that you will have a randomized trial in this. Then in advanced pancreatic cancer, do we have to treat by NACT followed by surgery and then adjuvant chemo? Chemotherapy preferred in metastatic prostate cancer. So I didn't understand the question, Ankita. So you mean, do you mean locally advanced? If you mean, in early pancreas, we have resectable, borderline resectable, and locally advanced. So again, if it's a locally advanced cancer, the Alliance trial there were 2 trials which we discussed last time, the LAP-07 study, which actually was stopped early. There was it failed to me. So there was, I think, because of futility reasons, the trial was stopped. But again, there's a lot of data with the use of SBRT, which is quite popular in pancreatic cancer now because it's more accurate. So my practice is in locally advanced, I give FOLFIRINOX or Gem-Nab-Paclitaxel neoadjuvant because there is good data in that, followed by we rediscuss the patient in the tumor board with a pancreatic surgeon. And if the downstaging has not been enough, which it may not be enough, then I would go for chemoradiotherapy, and we would go for Gemcitabine radiotherapy, followed by reassessment and surgery. So yes, in locally advanced we do. And in fact, I've sent this agenda on our group on 21st, 22nd. So we have Dr. Karen Goodman, who's going to talk about neoadjuvant chemoradiotherapy, the evidence for that. And then we'll have Dr. Eileen O'Reilly, who's, one of the leading person for pancreatic cancer from Sloan Kettering, talk about the neoadjuvant strategies, how do you choose between chemoradiation, because we discussed some very fantastic studies last time, 2 weeks ago, the SWOG S5105, and a few other studies as well. So how do you choose between chemotherapy versus chemoradiotherapy? I know we discussed a lot of it, but even I want to learn as to, what's happening around the world. So I think it'll be good if all of you can join that session on 21st is biliary cancers and 22nd is pancreatic cancer. So in all patients, BRCA test is a must, yes. So if you have a patient with pancreatic cancer, now all the guidelines recommend germline BRCA testing. It's a must. And in metastatic patients, you would consider a somatic, if you're doing an NGS, you would get somatic BRCA results as well. So very rarely, we had a patient recently where the BRCA test, I tell this example to everyone because again, it was a learning point for me as well. So I had sent the patient's germline BRCA test when they came to me originally, and I started the patient on FOLFIRINOX. The BRCA test was negative. So we carried on, and then the patient recurred 6 months later, and I sent NGS at that time. I usually do next generation sequencing at the time of first recurrence. I don't do it at diagnosis because we have enough standard of care treatments. So when we sent the NGS, we sent a ctDNA because the patient declined the biopsy. We sent a liquid biopsy. So that came back as positive for BRCA2. I was very surprised because, I thought, how can the somatic be positive, germline negative? It is possible, but I thought, let me recheck the germline. Then I rang the company and said, do you mind rechecking that, whether the patient, mainly implication for the siblings and the patient's children. The patient had 3 daughters. So so they then came back to me and told me that the BRCA that the company had done was by NGS, and we should order an MLPA, which would, because NGS misses out the large deletions. So when we resend the blood sample for BRCA, the patient came back as BRCA positive. Now, I would have given this patient maybe Gemcis if I had known earlier that the patient was BRCA positive. So be very mindful, if you see a result, always question it and go back and recheck it. So BRCA testing is a must in all patients. Then which chemotherapy preferred in metastatic prostate cancer? You mean pancreatic cancer? So metastatic pancreatic, again, I have no preference between FOLFIRINOX and Gem-Nab-Paclitaxel, because if fit patient, I would give FOLFIRINOX and at recurrence give Gem-Nab-Pacli. Or if I've given Gem-Nab-Pacli before and at recurrence, if the patient is fit enough, given FOLFIRINOX. So I recently had a patient, we started with Gem-Nab-Pacli, but at recurrence, I didn't think the patient was fit for FOLFIRINOX. So we gave FOLFIRI. Then we gave Capox. And then we gave paclitaxel carboplatin. And I think we've held the hand of this patient for 2 years now. So, yes, targeted treatment, all this is quite important. But in pancreas also now we are talking of first line, second line, third line, fourth line. In fact, I'll discuss this patient next week on Saturday. On Friday, on 14th, 15th, you have the New York debates, the GI New York debates. So if any of you, I've asked them whether I can have some complimentary passes for some of my students. And so they are looking into this. So if they do give me some complimentary registrations, I will share it within the group. So one of you or few of you can join the New York debates, because it's all on GI. And I find it very interesting. So I'm discussing this case as part of the molecular tumor board in that. So is BRCA positive, good PS, what to choose, FOLFIRINOX or Gemcis? So, I would go for Gemcis because again, the data is coming, and a lot of us are giving gemcitabine cisplatin in patients who are BRCA positive, because again, it's a it's because of the DDR pathway. The role of BRCA in curative setting to select chemotherapy. So this is the only time, we would give Gemcis. And the other thing is, within 2 cycles, you will know that the patient is responding. So whether the CA19-9 has gone down, if the CA19-9 is normal, by the way, I always tend to do in pancreas CEA and AFP. Because like I said, if you have an acinar pancreas cancer, the AFP may be raised. Very rare, but it's possible. And if you've had a long career, you will see these patients in your clinic as well. So the reason I do this is I want to find a marker that because it's not possible to keep doing scans every time. So you can have a marker. You may have the marker going up after the first cycle, which is we call as tumor flare. But afterwards, the marker should, after 2 cycles, start to go down. So, if the patient is not responding, you can switch to FOLFIRINOX quite early on. So that's how to choose chemo in palliative setting. Again, palliative setting is all dependent on performance status. Good performance status, I would go for modified FOLFIRINOX and reserve Gem-Nab paclitaxel for later. Because, about 50% of our patients do not get to second line chemotherapy. So what you want to do is give the most effective regimen first. And because, half your patients will not get second line. And again, third line is 10 to 15% patients who get on to third line therapy, and probably 5%. So this patient's example I'm giving you is in that 5%. He's a young, fit gentleman who's gone on to, third line chemotherapy, which is very rare in pancreas. It's common in breast cancer, common in colon cancer, but very, very rare in pancreatic cancer.